My name's Michael Fine. I'm a writer and community organizer, a family doctor, and a public health guy, and president and board chair of Primary Care for All Americans. Thanks to all of you who've been part of one of our Zooms before, or who have volunteered or have contributed, and welcome to all those who are joining us for the first time. People from 27 states and the District of Columbia and more than 211 zip codes. People who've come together to build the movement and a healthcare system for the United States that is for people, not for profit, and starts by providing primary care to everyone in every American neighborhood and community. Primary care is an essential service like police and fire protection, or clean water, or roads, or public transportation, a service that everyone who lives in these United States should have right near home. You're going to hear tonight how people like us in the great state of Massachusetts are bringing primary care to everyone who lives there. Our first task is to help support not just Massachusetts, but 25 communities in 5 states as they commit themselves to providing primary care to all, so that we can reduce the cost of healthcare as we improve the public's health. That means we have to be working in our communities, working hard in our communities, while we also fight for new nursing and medical schools that can train a zillion new nurses, doctors, and other health professionals from our communities to go back to work in those communities. So we all have great people to take care of us right at home. Please stay on our call afterwards with our board to hear how you can bring primary care to everyone in your own neighborhood and community. It's now my great pleasure to introduce our moderator for this evening, Dr. Donna Smalls, and to thank the Zoom Committee of Primary Care for All Americans, which organized this Zoom, to thank Dr. Altman and all the presenters, and John Wright, Brian Kaiser, and Patty Armstrong, our great and ace Zoom producers. Take it away, Dr. Smales. Got it right the second time.
Good evening. Yes, you did. Good evening, everyone. Thank you all for being a part of PC4AA, Primary Care for All Americans. Where together we are building a movement to provide healthcare for all people. Healthcare for people, not for profit, in every neighborhood and community. Now we'll hear something in Spanish for all of our Spanish listeners.
Bienvenidos. Los subtítulos en español están disponibles en los subtítulos ocultos. Nuestro sitio web también ha sido traducido al español para que pueda obtener más información sobre nuestros movimientos. Cuando defendemos la atención primaria para todos, nos referimos realmente para todos.
Tonight, we are here both to teach and to learn from each other. We encourage you to ask questions, put them in the chat, and we'll have time at the end to answer as many as possible after we hear from our keynote speaker, Dr. Wayne Altman. Before that, we have Kristen to tell us about her experiences accessing healthcare. Hi, Kristen. Can you tell us where you are from and share about your experience?
Hi, thanks so much for having me. So I'm Kristen Carbone. I'm coming to you from Providence, Rhode Island. I am the CEO of a women's health startup and the mom of 2 teenagers. And I moved to Rhode Island about 12 years ago. And when I needed to find a primary care physician and couldn't, I reached out to a friend's mom who had been living in Rhode Island for decades. And she found me an OBGYN who I used as my primary care physician for probably the next 4 or 5 years until she retired. And then it took me like more than a dozen calls to find a new primary care physician who was accepting new patients, but also my insurance. And I adored her. She was wonderful, and stayed with her until she moved out of state. And then it was the 3rd time in a decade that I was looking for a primary care physician, and I really couldn't find one. I ended up talking to a friend who is like me in her 40s, but still sees a pediatrician. And she connected me to him, and he said, He would happily see me in a pinch, like if I had a sinus infection, if I needed some support, but that's kind of as far as I went. And a little bit about me, I have Hashimoto's syndrome, which is an autoimmune disease that affects my thyroid. And it's really important for me to have a primary. As the woman who kind of impromptu kicked off this call mentioned, it's really important to have someone who's kind of overseeing the entire continuity of my care. And it's been really challenging because there's been so many changes. And as I also mentioned, I'm running a women's health startup, and I have a number of local physicians who are on my advisory board who also have been like unable to help me find a PCP. They've been great when I need a specialist and make good recommendations, but kind of just shrug when the PCP conversation comes up. And I think it really is absolutely critical for everyone to have access to a primary care physician. And I'm really excited about the work that everyone here is doing. So thank you so much, and thanks for having me.
No, thank you. Thank you for sharing your thoughts and experiences. Now we are pleased to introduce our keynote speaker, Dr. Wayne Altman. He is the Harris Family Chair and Professor of Family Medicine at Tufts University School of Medicine. Dr. Altman practices at the Family Group in Arlington, where he is president and co-owner of the practice. He is a board member for the Massachusetts Academy of Family Physicians and serves as their legislative committee chair. He is the chair of the Advocacy Committee for the Association of Departments of Family Medicine. He was presented the 2023 Advocacy Award by the Massachusetts Academy of Family Physicians. Thank you so much for joining us, Dr. Altman.
Well, thank you so much for inviting me, and thank you for that kind introduction. You did forget one piece in my introduction. I am a proud member of Primary Care for All Americans, and I'm really excited to tell you an interesting story about what has been happening in Massachusetts. If you don't mind me sharing my slides for just a moment. So, you know, we have we've been doing a lot of work over the years to try and reform healthcare. And we seem to be making incremental changes. And as a physician, if I treat my patient and just treat their symptoms without addressing the root cause of a problem, I'm really making an error in the care of that patient. And we've made the same error with health policy in this country as we try and just put little incremental band-aids on one problem after the next without addressing the major problems that we're trying to deal with, which is a shortage of primary care and not enough primary care access. So we have been working for 5 years now on legislation that we call Primary Care for You, or PC4U, or S.750, which is an optional primary care payment model that we think everyone will opt into once this legislation is passed. And I'd be delighted to tell you a little bit about this legislation. In short, it doubles primary care investment, and we'll talk about what we mean by that doubling in a moment. And it creates a predictable prospective primary care payment instead of fee-for-service. Never in American history have we doubled primary care investment and created a prospective payment model for an entire state or an entire large community. And we will also improve health equity and begin to dismantle systemic racism in healthcare. There is no more powerful lever to pull in terms of health equity than increasing access to primary care. And we believe that primary care is a public good, should be a public good for every resident of Massachusetts, for every person in this country. And so did the 2021 NASM report that said that primary care is the only healthcare component where an increased supply is associated with improved health and decrease inequities. We're the only part of healthcare that can pull off that double bonus of better health and decreased inequities. And so while many people have been proponents of Medicare for all and a single payer system, this is a little bit different. What we're talking about here is primary care for all. And for those who are big fans of Medicare for all, and I'm one of you, primary care for all would be a great step in that direction to start moving in that direction. We are not alone. There are over 20 states that are working on similar legislation to increase primary care investment. And the burning platform is simple. I don't think I need to convince any of you. Our previous speaker told us about poor access to primary care, and unfortunately, she is not alone. I hear from countless people of all socioeconomic strata of the challenges of accessing primary care. And when people do access primary care, it's because they know somebody and they have a higher amount of privilege in their life. And not everybody has those connections and has that privilege. And so many people are living without primary care as a result of that. Even those with care are suffering the exorbitant cost of healthcare, in part due to copays and huge deductibles that stand in the way of a patient and access to primary care. And there are still, in 2024, large health inequities. So we talked about doubling primary care investment. Depending on how you measure it, about 6 cents of every dollar in Massachusetts goes to primary care. 6 cents of every healthcare dollar goes to primary care. And what we're talking about is over a 3-year period, doubling that, getting to the sweet spot of 12 to 15% of total medical expense being allotted for primary care, as is in the case with most developed countries who have a more robust primary care system, and as a result, way better outcomes in these great United States of America. One other aspect of our legislation is to create a group of what we call the transformers. And this is all the good stuff in primary care that we love to offer as part of primary care, but can't afford to do so because fee-for-service doesn't pay for any of these things. And so many practices offer a few of these things temporarily based on grants, or they just lose money out of the goodness of their heart because it's really important to offer it to their patients. But these are some really critical ways to increase the quality of primary care for our patients. And this legislation incentivizes primary care transformation with all this primary care candy, integrated behavioral health, group visits, addiction treatment, community health workers, telehealth, scribes, care managers, all the what I call primary care candy. And in this legislation, we address risk and social drivers of health. Right now, doctors get paid more if they take care of more complicated patients. However, the algorithm that determines what makes a patient complicated is limited to their medical history and nothing about their life and their social history. So if a patient has housing difficulties, food insecurity, difficulties accessing transportation or healthcare, these are not factored in. And so in this legislation, we will use something called the neighborhood stress score that can use a patient's street address, not zip code. Zip code won't do it. Street address to and census data to predict the social complexity and marrying both the medical and social complexity in order to determine where resources should be allocated. Amazingly, the current algorithms assume that where resources have historically been allocated is where they probably should be allocated in the future. However, historical allocations of resources in healthcare have gone to those with privilege and have not gone to those who've needed more of those resources. And so this would break down that systemic racism that is in this algorithm and change it to allow for, oops. It is not advancing. Well, while I figure out how to advance this slide, the next slide talks about quality measurement. And that's one other aspect of this legislation is to measure quality. Now, currently we measure quality with hundreds of measures. This would identify 10 measures that are very important to patients and that are based on evidence. The other thing, and I've sort of buried the lead, is that with this legislation, there are no copays and no deductibles. This is free primary care for every soul in Massachusetts. I've identified the superpower of primary care to deliver health and equity. And yet we put an obstacle course between our patients and primary care. And there would be no cost sharing in this legislation. So I'm not going to get too much into the weeds. We certainly can talk about things when there's time for questions. But we establish a monthly baseline payment, and then we double that based on the amount of transformers that a primary care practice attests to investing in, account for the quality, account for the risk that we talked about, and establish a prospective monthly payment. And this payment would be delivered to primary care practices from a primary care trust overseen by the Massachusetts Health Policy Commission that would collect money from the insurers. And so it takes insurance out of primary care. Insurance is for catastrophic and unexpected results. Primary care is neither catastrophic nor unexpected. And so it really doesn't belong as part of the administration of primary care. One of the concerns people have had with this legislation is it's great that you're doubling primary care investment, but how can you be so sure that that money will actually end up in primary care practices for primary care? And in this legislation, what we say is that 95% of the money earmarked for primary care must go to primary care for primary care on the practice level. It cannot be on the system level because systems will suck up that money and use it for other things besides primary care. And our Health Policy Commission would be authorized to audit large health systems to look into making sure that a minimum of 95% of primary care money went to primary care for primary care. We've just completed a simulation about this legislation, and as we suspected, there is a very robust return on investment from doubling investment in primary care that starts to pay off after 4 years of the program. The total medical expense will start to go down after 4 years of investing in primary care. But in the meantime, we have to pay for those first 4 years without increasing the cost of medicine. And our proposal to do that is to have the large hospitals and the commercial payers share in that investment and share in that cost by a slight cap on the rate of price growth for large hospital systems, as was done in Rhode Island and Delaware, and a very small tax on commercial insurance. And it will pay big dividends for both the hospitals and the commercial payers. We're very proud that we've been endorsed by 9 different organizations, including the Massachusetts Medical Society, a major healthcare system, Healthcare for All, which is the largest patient advocacy organization in Massachusetts, the 3 primary care organizations in Massachusetts, the NPs, the PAs, the mental health folks, have all endorsed this, and we have some new endorsements that we think are forthcoming. So the idea here is we have a current healthcare system that is based on profit. The forces of profit deliver what we have in our current healthcare system. And the only way to overrule the forces of profit is to legislate on a state level, and so that health and equity overrule profit and self-interest. And I will stop there and say that if you are in Massachusetts, please do email your state rep and state senator and ask them to support PC4U or S750. If you are outside of Massachusetts, tell your friends in Massachusetts, and please spread the word about primary care for all Americans, because this is a movement that we all need to get behind. And now I will stop sharing and hand the baton back to Donna for questions.
Yes. Thank you so much, Dr. Altman, for your encouraging and motivating words. Do you have a question for him? Please post it in the chat and we'll answer them in a moment or later on our social media pages. While you submit your questions, let me introduce Drs. Aliyah Shafi and Gabriella Yaru, my colleagues at Jamaica Hospital, who remind us of why this work is so important.
Hi, everyone. Primary care is an essential service. When everyone has primary care, we can stop the spread of hepatitis C, HIV, and eliminate colon cancer, using the science we have today, and save 100,000 lives in this country every year.
Primary care strengthens communities. When everyone has primary care, people can get their health care near home and can spend more time together.
When everyone has primary care, we'll spend far less money on healthcare as a nation. So there'll be more money to spend on education, safe and healthy housing, public parks, the environment, and communities. What really matters for health.
We mean everyone. When everyone has primary care, and when communities can get primary care from doctors and nurses who are part of the communities they serve, the health of all people improves and improves together. But this starts with you. By joining us tonight, by learning about how communities can provide primary care to everyone, and by bringing someone new back each week, we'll build this movement that brings primary care to everyone, and at the same time, bring better health and stronger communities. We aim to ensure all persons receive equal health care and get equal health regardless of where they live, how much they earn, what community they come from, or what they look like.
Coming together for this teach and learning, we are that much closer to bringing primary care. Together, we can build a health system that is for people, not for profit. And yes, we can provide primary care to all Americans in every American neighborhood and community. Now let's get to your questions. Patty, can you share some questions from the audience?
Absolutely. All right, Dr. Altman, you ready?
Bring it.
All right, so can you talk a little bit about the ways that PC4U will make things better for patients and the communities we live in?
Well, PC4U is going to build primary care capacity. Primary care is a very powerful lever that delivers health and equity and lowers cost, but we don't have enough of it. And so what primary care for you is it delivers, it helps with the shortage of primary care, both short-term and long-term, because these transformers allow you to invest in teams and allows me to take care of a population of patients instead of one patient at a time, one office visit at a time in a fee-for-service environment. When I have a more robust team, when I have a care manager and integrated behavioral health to help with mental health for my patients on site, and I have a medical scribe, and I have a dietitian, and I have group visits it increases, even if you don't make more of me, even if you can't clone me, the primary care doctor, I can do so much more by working with this robust team. The other thing we were talking at the beginning as people were coming into the Zoom is that there are a lot of people who are decreasing their hours because they're so frustrated with what is going on. And so if you fix the job, people stop leaving early, people stop decreasing their hours, and you can have an immediate return on investment in terms of workforce. And if you're fixing the job and investing more in primary care, thus now you're going to increase the likelihood of medical students choosing primary care, and now we'll have a long-term return on investment with primary care as well.
So you're talking about return on investment. Can you talk a little bit more about if PC4U will cost more money in the long run, or is it going to save money?
So what we learned with this simulation is that right now, Massachusetts pays about $70 billion per year on overall healthcare, all of it. Okay. Now, after 40 years, and they have a figure in Massachusetts called the cost growth benchmark, which allows the healthcare cost to grow by 3.6% every year, limits it at that 3.6%. There's no absolute teeth with that limit, but it's like a please, pretty please, can we not grow by more than 3.6%? The cost is already ridiculous. Can we cap it at 3.6%? And what we think is not only will that 3.6% number start to go down over the 40 years, but we think that number can turn into a negative number and save a lot of money, not just for people and citizens, but also for businesses and also for the Commonwealth and for taxpayers.
Wow, that sounds great. I love that. So you mentioned in your slides how people can help get PC4U passed. Do you mind just saying again what people should do as a group that is obviously passionate about this? How can we take action?
Well, if you're in Massachusetts, emailing your state rep and state senator and encouraging them to get this law out of committee and pass this legislation would be welcome. You can go to pc4u.org, the website, and learn more about the legislation. You can share it with your state rep and state senator. And that would be a good way for starters.
Sounds good. There are a lot more questions that we want to get to. There will be time at the end of this session to actually come off and discuss with Dr. Altman and some of the board members. But thank you so much, Dr. Altman, for your time and for sharing your insights on primary care. We will also be taking a look at the questions that you have all submitted by our team and post on Facebook and LinkedIn pages. So don't forget to follow us there too. Dr. Fine?
We can't hear you, Dr. Fine.
Oh, Dr. Fine, I don't think we can hear you.
Somebody in the chat asked, thank you, asked, can't we do this as a nation, not just state by state? And I think what we've discovered as part of primary care for all Americans is that we have to do it as a nation. We have to do it state by state. We have to do it community by community. That's what building a movement is about. There's so much money involved in keeping things the way they are that it's going to take a social movement like the abolitionist movement, the movement for women's right to vote, the civil rights movement, or the movement for marriage equality. It's going to take that number of people working together at all levels in order to get this done. And there are zillions of ways communities can do this. Local health alliances, community-owned health plans, new and recharged community health centers. We're going to be talking about all of those in subsequent Zooms, and perhaps a little bit in the question and answer period tonight about the strategy we have for motivating everybody in communities, in states, and in the nation as a whole to get this done and get this done together. It's really important. Healthcare impacts all of us. But when we work together, there's nothing we can't do. So please join us and reach out to colleagues, family, and friends. Bring people in. Bring people to our subsequent Zooms. Send us emails. Volunteer if you can. Contribute if you can. Let's all reach out to everyone. This isn't a Republican thing. This isn't a Democratic thing. This is an American thing. The cost of healthcare affects all of us. We are the public in public health, and the time to change this is now.
Thank you. We encourage everyone to find someone new to get involved in this impactful movement and bring to our next Zoom meeting on February 20th. Our speaker is Jewel Mullen, Associate Dean for Health Equity at Dell Medical School, the University of Texas at Austin. Dr. Mullen previously served as a Principal Deputy Assistant Secretary for Health at the United States Department of Health and Health Services. Register on our website at www.primarycareforallamericans.org. And while you're there, click volunteer to tell us how you'd like to be an active part of our movement, and donate to support our work together with a contribution. Every little bit helps. Once again, we need and appreciate every single one of you for helping us spread our movement across the nation in order to get the change we need and you deserve. Join us again in 2 weeks. Bring one person each time. Better yet, bring 3 or 4. Healthcare for people, not for profit. Primary care for all Americans.
There is an opportunity on February 21st to have an additional discussion. Brian Kaiser, can you tell us more?
Yes. So we have this event to announce. It's outside of our regular meeting schedule. As those of you who are in Massachusetts probably know already, private equity-owned Steward Health has announced that they will be closing, or that they may be closing, some of their hospitals and health centers. So on February 21st, in association with Families USA, Take Medicine Back, and the Milbank Fund, we will be holding an emergency meeting, what patients and communities can do when their private equity-run hospital system goes belly up. The short answer is that communities can bring primary care for people, not for profit, to their own communities. But you guys already knew that because you're on this meeting. But it's going to be a great and important conversation on an urgent issue. So if you are concerned about hospitals and health centers closing, about private equity in healthcare, as I know some of you are because I saw some of your comments in the chat tonight, I encourage you to join us for that and watch your emails for an invite. You'll be getting one.
Thank you so much, Brian. Please take a minute to complete our survey. The link is in the chat. We do want to hear from you. If you'd like to talk with members of the leadership team, please stay on our call, and board members of PC4AA want to stay on and hear your feedback. Help us grow as a community.
And Dr. Altman's going to stay on as well. So you can ask your questions of him, directly to him.
Thank you, everyone. See you on February 20th.
21st?
20th
21st.
and 21st.
Oh,
20th for our next regular Zoom, the 21st for the emergency Zoom about the potential closure of hospitals, mostly in Massachusetts. Any questions from the audience?
There is a great raise hand function at the bottom of your screen. It kind of puts you right in the queue. And Dr. Fine even knows how to work that really well. So if you click that raise hand button, you'll be up next in line.
Eliana?
you're muted, Eliana.
Sorry. Is there a way that we could get a copy of the actual legislation or some kind of bullets thing? Because as I mentioned, if you call your congressperson, it's really helpful for you to be able to say, here, this is what I want you to introduce. This is what I want you to support. Because a lot of times, especially if you're saying something they haven't really heard about before, they have no idea what you're talking about. They're in a mad rush. And you probably get their assistant who has to pass the message on like telephone. It becomes somewhat garbled before it gets where it's going. So it'd be great to have a copy of what you folks have worked so hard to put together.
So what I will do is I will put into the chat my email address. And if you email me, I can send you all that.
Thank you.
And Dr. Altman, if you will send a copy to me, a recent copy to me, we can put it on our website and circulate it as well.
That'd be great.
Michael
Okay, we'll do-
Kaplan, how are
Hello.
things in Western Massachusetts?
Western Massachusetts. So I've been a single payer advocate for as long as I can remember. And so when I'm talking with other folks that want single payer and feel it's the answer to get everyone covered without copays and deductibles, and I say, well, let's do primary care for all. They say, well, how are you gonna make it so people get specialty care? To really have equity, you can't just offer primary care, or you have a two-tiered system, those that do and don't have the extended care. So how does that get handled in this system?
Dr. Altman, you want to go first?
Are you talking about in a Medicare for all environment or in a PC4U environment, Michael?
Talking about PC4U and Medicare for all, we know that every doctor will be covered, and all hospitals are covered, and but that's not going to be true for once you get out of needing only a primary care doctor. What do we do? What did they do then? Because
so
not
specialty
everybody will
care,
have it.
simply put, specialty care will be status quo, no change. Insurance,
Michael,
fee for service.
So that's
And Michael-
cruel. You go for primary care. Your primary care says you really need a cath or whatever, and then you can't get in.
Michael, can I jump in?
Please
I mean,
do.
from my perspective, in a certain way, the perfect is the enemy of the good. That it is not perfect in the first instance, for sure. But it is way better than what we have, and will have a huge impact on cost. And my hope and expectation is that when we get everybody primary care, and reduce the cost of medical care by 20 or 30% or more, which is what we are likely to do, we can take the almost $1 trillion that we'll save and use it to expand access to specialty and other care, but with the advantage of when everybody has primary care, everybody's best guess is that emergency department utilization and unnecessary radiology and unnecessary specialty care will also decline pretty radically. Dr. Connard from Texas.
Yeah, hi. Yeah, so Michael, can you hear me okay?
We can hear you loud and clear.
Yeah,
Dr.
so
Connard is a member of our board.
Yeah, and Scott Connard, family doctor. I run a data analytics company. And you'll be really relieved and excited to know, Michael, that when we look at the data, what we see is that 70%, that's 70% of the catastrophic issues that occur for patients could have been prevented if they've gotten appropriate primary care. So if you think that, if you look at the numbers, and this is like true to life, follow the population. And again, Alan Roth, who's on here, is an expert at this also. When you look at there, 30% of the people that will have events that will become 8% of the people who spend 80% of your money in a healthcare system. And 70% of the people that you could have taken care of that became high cost and didn't need to become high cost, if you just get the savings for those, there would be specialists available for everyone. There would be hospital rooms available for everyone. The problem we have in the United States is not that we don't know what to do, it's that we don't give people access to high quality, trustworthy care where they have a great relationship with their primary care doctor, and therefore unnecessary things happen. And that's really, you could also call this movement Stop Unnecessary Catastrophic Health Events, and it would be equally accurate. So the money takes care of itself when people get trusting, reliable care in primary care. The rest of the system unfolds. It just literally starts to function the way it should. Right now, because we have a very dysfunctional primary care system, all this extra burdens put on specialists, all this extra burdens put on hospitals, all these unnecessarily events occur, and so money is spent that would not be spent in a system that is right-sized. And if you don't believe me, I've got the data. Don't trust me because I'm a doctor. Trust me because I'm an analytics nerd who looks at data all day long.
I believe you for both reasons. The challenge, the challenge is we're in an environment where it's a struggle. We're in a political environment where delayed gratification is a challenge.
And we're in an overall environment where there's what $718 million a year that's being spent by people with something to sell on keeping things the way they are. And the only way we're ever going to get around that, the only way we're going to get out from under it, is to build this kind of social movement. Brian.
Yes, there were several questions in the chat about private insurance and insurance companies and how what Dr. Altman is talking about will relate to private or to insurance companies. Will they contribute? Will primary care capture their premiums? Things like that. Do you want to address some of those things?
Sure. So
I'm asking
right now, say again, Brian?
I'm asking for 3 friends in the chat.
Excellent. Right now, in Massachusetts, every dollar that commercial payers pay to hospitals is taxed at 1.35%. And that based on legislation that forces them to do so. They wouldn't do it out of the goodness of their heart, I can guarantee you that. And that 1.35% goes to creating a health safety net for patients who are uninsured or underinsured, which is now a pretty small amount of people because of the legislation. It's about 2% of people in Massachusetts. In order for the payers to pay their fair share to invest in primary care in Massachusetts for every soul in Massachusetts, that 1.35% would need to go to 1.85%. We're not talking about a dramatic sum of money or a game changer that moves the needle for these companies that have billions of dollars in reserves.
Dr. Roth, another member of our board.
So kind of the answer to the question is what happens to the patient that needs the cath? Well, most likely that patient didn't need the cath because most elective catheterizations are unnecessary, as we know. And in the few patients that truly need the cath, it's an emergency situation. And the primary care docs are going to open up the EDs so the patient could go in and get the emergency cath they need. So we're going to answer it in both ways by decreasing the need for the tests and opening up the capacity for those that truly need the tests.
Well said. The Massachusetts Medical Society endorsed this legislation. This is a society of the vast majority specialists. So that was a pleasant surprise for us. But what we discovered is that the specialists are really overburdened now with patients that they don't want to be taking care of, because primary care should be taking care of these folks. We want to be taking care of these folks. We don't have the capacity to take care of these folks. And when we have that capacity, primary care can actually do their job better. And I think you just articulated that beautifully.
Rick Brooks had a question. I don't have it before me. Rick, if you're still on, do you want to come on and just ask it yourself? I don't mean to put you on the spot, but if you can, come on. If not, are there other questions or comments?
Are you asking about Rick's question about the percentage of commercial insurance premiums, or did he have a different question?
I think that's the one I saw flash by me.
Okay, yeah. How will you capture the percentage of commercial insurance premiums that currently pay for primary care?
Right. So the idea is to create a primary care trust overseen by the state government that, let me give you an example. I'm a co-owner of a private practice. And let's say we have 1,000 patients who are with Blue Cross Blue Shield. And let's say our PMPM, we get $60 per patient per month. And so what happens here is that the trust will bill Blue Cross $60,000 a month, $60 times 1,000 patients, and deliver that $60,000 to our practice. So instead of dealing with 20% of claims that got unpaid and blocked for some ridiculous reason, and then having to resubmit those claims and deal with all of that stuff and hire lots of people at our practice to fight with the insurance companies, we can hire people to take care of patients.
I'm curious. I see there are a couple of people on who are currently located in Florida. I'm curious about what you guys are seeing in terms of workforce and access to primary care. Are there enough clinicians in Florida?
Stop it.
You're
throwing out softballs.
Somebody want to talk at all about what they're seeing and hearing in other parts of the country? Deborah? You're still muted.
Yeah, I'm retired, but I can tell you that it's almost impossible to find a primary care doctor in Florida, whether family medicine or internist. So I tend to be a resource for a lot of people who are asking me, about their issues, but to get an appointment can take months and months, even if they're taking new patients. And most of the doctors who are in practice are going into concierge medicine. So that's a whole nother problem.
I have a mother that lives in Florida, and that was exactly what I was going to say. It's not a problem to find a PCP in Florida, as long as you have a few $1,000s to spend per year to sign up for a concierge doctor.
Right.
How about in California? I think I saw a couple of people on from California. Anybody? Larry, did you have something you wanted to contribute or tell us about how things are in Pennsylvania? Larry's another member of our board.
So I actually have a question for Dr. Altman. Wayne, it's good to see you again. It's been a while.
Hey, Larry.
You're chair of a department of family medicine, last I looked. And we don't have enough people coming out, graduating from medical school in family medicine, pediatrics, and general internal medicine. And I'm wondering what your perspective is on how our organizations, our advocacy organizations, might influence that, through the deans. I'm sure you know the deans in the state of Massachusetts, or at least your school. Is there any hope for influencing them to look at their admissions process so we get more of the right kind of people coming in who will choose primary care for their careers?
You know those movies, Larry, where you see the end of the movie first and then the whole rest of the movie leads up to it? I'm going to do that with my answer. So the end is primary care for all Americans. That's the end of the movie. Okay. Right. Here's the beginning. I'm so glad you asked the question. I really appreciate the question. I've been thinking about this for a long time.
Wayne, I think you're frozen.
So I think the question
arrived at
stumped him.
Tufts Medical School back in 1998. We had about, am I back?
Yeah.
Yeah.
I'm back? So when I started at Tufts, we were at like 3-4% of students going into family medicine. And we got up to like 10-12%. We had so much success that the American Academy of Family Physicians called us a positive deviant, to which I said, thank you, I think. And it's nice that we got to 12%, which is 24 students out of 200 in our class, but it's nowhere near enough. The American Academy of Family Physicians talks about 25 by 30 campaign, having 25% of students in family medicine by 2030. It's not realistic and it's not enough. I think we should have a 40 by 40 campaign because we need closer to 40% of people choosing family medicine. And the only way we're going to do it is if we fix the job and fix the pay. And that's what primary care for you is about. It's about fixing the job and fixing the pay. Because if we can do that, and then we can increase the workforce in primary care, that's our only chance to have primary care for all Americans.
Just some numbers. In the United States, we have 21,000 medical students a year across the country.
Graduates.
And now something like 20%, or between 4,000 and 5,000, are going into primary care. Some of us think that the deficit is more measured in hundreds of thousands of people. And so part of the challenge that we face as an organization and as a movement is working in every state, not just to increase the number of people who are choosing primary care, but to quadruple the number of medical students, nursing students, and PA students, so that we massively increase the primary care workforce. This is an issue that we haven't even scratched the surface of this issue as a nation, and yet it's determining the future of our country and profoundly influencing both the cost of healthcare and our public health outcomes. Other questions? Anybody else? Eliana, you're muted.
Yep, I thought of it this time. I actually would like to do a quick report on New York State. A lady who's like a sister to me lives in the Catskills. They've retired up there, and there's actually quite a few people retired up there. And she has to drive to Albany and Oneonta to get primary care or medical care, and gets canceled because they're so overbooked. And she and her husband are both in their 70s. Driving around on slippery winter roads for miles and miles just to see a doctor is ridiculous. But they do have something that I was really impressed with that I actually saw because we were visiting them when it happened. Some kind of home health care worker came to visit. Both her and her husband had their appointment together. And they had their blood pressure checked and all that. They got a lecture on drinking enough water. And the woman was great. She was very funny. And so they did get some kind of basic care. I don't know how the state of New York pays for that. It could be because they're senior citizens, but that part was good. But the rest of it is an ongoing nightmare. Anything they need, especially primary care, means driving for hours on unsafe, twisty roads.
Thank you for that. Actually, in a month from a month, almost exactly to the day, we will have as our main speaker the director of the New York State Department of Health. And we'll get to talk to him about what's going on in New York directly. Dr. Meltzer.
Evening, good people. Thank you very much for the presentation. That was very informative. I did practice medicine for more than 30 years in a specialty because it was more glamorous, which is something that is not something that we can really change, I don't think. But anyway, my question really involves how is the increased use of PAs and NPs impacted the access to primary care, and should that be further enhanced?
It should. We need more PAs and NPs going into primary care. Sometimes our societies fight against PAs and NPs, and I think it's foolish to do so. PAs and NPs are our very well-respected colleagues. Michael was just talking a moment ago about the incredible deficit of primary care. We need PAs and NPs by our side. The problem is they're not choosing primary care for the same reason that MD grads are not choosing primary care. And again, we need to fix the job and fix the pay.
Only 17% of PAs are choosing primary care. Dr. Conard.
Yeah, I could not agree with Wayne more. You know, it's interesting because the mindset of allopathic medicine is transactional. Get in, figure it out, send them out, get done what you need to have done. One of the beautiful things about nurse practitioners is they have a relational mindset where they very much are about teaching. And we cannot have enough teachers that raise the health literacy of people about their chronic diseases. And so nurse practitioners, well, if someone comes in with an acute belly or with some, pelvic pain that's rare and obscure, are going to need to ask for help from hopefully an overseeing or a collaborative MD who's got a lot more experience, or DO who's got a lot more experience with those really rare cases. The 90% of US healthcare today is in people with chronic and mental health diseases. And so we need those social workers. We need those nurse practitioners working in a team-based care, as Wayne said earlier, to overcome the challenges we have in caring for the whole person.
Right on.
Thanks. Other thoughts or comments? We're almost out of time. Hearing none, let me thank Dr. Altman yet one more time for the work he's doing in Massachusetts and the leadership he's showing and the courage that it takes to do that. And thank him for being with us tonight. Thank you all for being with us tonight. Remember, movements happen when people bring other people. We'll meet again in 2 weeks and hope you bring 1, 2, 3, 5, 10 others. It's really easy to invite other people using our website. There's a little button that goes invite others. When you get the announcement, the little electronic poster about the next meeting, please send it to a few other people because that's the way we're going to make this work. Like I said, we've already got we're in contact with people from 27 different states plus the District of Columbia, 211 zip codes. Now we have to get to 50 states and as many zip codes as there are, and really get going, changing the reality on the ground in every community, in every neighborhood, in every state, as they used to say, from sea to shining sea. Thank you all again. Thanks to our support folks, and we'll see you all in 2 weeks.
Great job, Wayne. Thank you so much.
Thank you all.